evening and good morning, friends. Welcome back to international webinar on pediatric airway programs. Today we have a very important session with, as such pediatric airway problems demand teamwork. Our important teammates are our anesthesiologists. Okay, so today we have a program oriented with anesthesiology, that is challenges, anesthetic challenges in pediatric airway. With this, I hereby invite Dr. E. V. Raman sir to moderate this program and conduct the program. Welcome, sir. Yeah.
Thank you very much. It's a privilege and honor to have this set of webinars on the pediatric airway. And we are blessed to have a wonderful audience every time we host this. I welcome all of you, and especially Dr. Mughira Siddiqui, who's joined us from Karachi, from the Aga Khan University. Welcome, Dr. Siddiqui. We also welcome Dr. Ramesh Deka, a very famous ENT surgeon who was the director of the All India Institute of Medical Sciences. It's an honor and pleasure to have you, sir. And we have a wonderful program here of expert speakers, and I'm sure the audience also includes a lot of wonderful airway surgeons. But we have a select panel to help us understand some of these issues. Dr. Deepak Mehta joins us as usual from Texas Children's Hospital, Houston, who's been part of our program for many years now. And we have should be joined by Dr. Sohit Kanotra very soon from University of Iowa. Dr. Karthik Balakrishnan from Stanford has just gone to attend an emergency. That's what otolaryngology is all about. He's gone to do an emergency bronchoscopy. Dr. Gautham from Guwahati, who has started a beautiful airway center there, is going to join us very soon. We welcome Dr. Anil Patel as an expert to make us understand or appreciate what work Rakesh has been doing. So we have a wonderful program ahead. I don't want to waste much of the time, but all I need to do now is to tell you the importance, and Deepak very rightly expressed his views on this particular session when he said this is probably the most important of all the episodes that we're going to have in this series, because you're only as good as your anesthetist. An anesthetist is the most, he's not a member of the team, he is part of you. And you need to work like pilot and co-pilot in these cases when you're sharing the airway. So having said that, yes, Sohit has joined us. Welcome, Sohit. So we are kicking off the whole thing. You see, these are the days when you design a product or you launch a product, you need to find out what the consumer actually wants. So we're kicking off this session with Dr. Shyan Vijayasekaran, who's joined us all the way from Perth. An excellent airway surgeon with a lot of passion. He's been part of our charitable airway program. He's going to tell us what we expect from the anesthetist. Unless they know what exactly we want, they will not be able to meet our needs. So he's putting up a wish list. And Shyan, welcome. Please share your thoughts with us. And then we go ahead with some excellent talks after that.
Thank you very much, Dr. Raman. So I'll start. This is the main entrance to the Children's Hospital in Perth. We're going to talk about what we need from our anesthesia colleagues. When we talk about the pediatric airway as a challenge, I really separate our challenges into two groups of patients. Those that are difficult to intubate, like this patient here, due to problems in the mandible, the TMJ, the supraglottic masses, for example, or problems in the tongue base, and then those that may have a problem in the subglottis. And then there are the patients who are difficult to ventilate, patients who need prolonged endoscopic surgery, patients who have, sorry, that was, somebody needs to...
Can you mute? Shyan has also been muted.
Yeah, Dr. Shyan, you'll have to unmute yourself. Yeah, okay.
Okay, here we go.
You'll have to repeat that slide, I think.
Pathology in the distal trachea, who you know, and any kind of tube is not going to work. So the pathologies like this, Beckwith vitamin, and then there are pathologies like this, you know, a mass in a lingual thyroid compressing the epiglottis, which can be a real surprise for the anesthetist who's not ready. To enable us to do endoscopic airway surgery, the wish list is that we have a patient that's breathing spontaneously to enable oxygenation and ventilation, and enable a view of a dynamic airway, because many of the pathologies we deal with are not fixed. Things like laryngomalacia, lesions that may move in and out of the larynx, tracheomalacia, external compression, and so on. And so when we're making a diagnosis, we really want a breathing patient who shows us what the dynamic obstruction is. But at the same time, we want the patient to be deep enough for instrumentation. And then not merely for us to instrument, but to make incisions, to laser, to inject, or to balloon dilate. We want a patient to be deeply anesthetized, yet breathing spontaneously. So the dynamic airway things, you know, the usual thing we see is laryngomalacia, but then sometimes it's a problem like this, patient who presents with acute airway obstruction soon after birth. You know, somebody puts a flexible scope down and says there's laryngomalacia, but you know they're much worse than that. And you do a bronchoscopy and you realize you're dealing with a type 4 laryngeal cleft. There's your carina and there's the stomach. The patient's unstable, they're desaturating, they're hypercapnic. And you know, you can try and intubate this patient, but it's not that easy. So you put the tube in the trachea and it falls straight into the stomach. You know, so, and at the same time, we don't want this patient to be paralyzed, because if they're not breathing properly, you can't do any of this. They'll obstruct and decompensate. That's the diagnostic side. And then we want to do things like this, surgery on an 8-month-old who's got severe OSA despite everything, and we're going to do something to their tongue base. They're a difficult intubation. And in this one, yeah, sure, you can intubate the patient, but you don't want a tube in the oral cavity, so you want a nasal tube, whilst you might do some kind of tongue-based reduction. And then you have a patient who presents like this with acute stridor, and sure, intubation initially might seem easy, but you know, by the time you intubate the patient, your tube isn't going to go very far because it's coming up against this 1 millimeter airway. And in that patient, once again, you want them as awake as possible. And then you want them as deep as possible while you do a balloon dilation. At the same time, there is no tube. You want to be able to dilate their airway with this balloon, and then give them an adequate airway, after which time you might paralyze them or whatever. Or you might say, well, actually, no, I want to do a cricoid split, by the way, because a balloon isn't actually doing what we want it to do. By the way, Mr. Anesthetist, Dr. Anesthetist, I still need the patient to be breathing because we can't put a tube in there. We need the patient breathing and ventilating, and the CO2 can't climb too high either, because you know that's not so good for anything. And so whilst we're doing this in a neonate, oh, by the way, and when we've finished doing the endoscopic cricoid split, we're going to balloon dilate, and then you won't have any oxygenation. And how are we going to manage that? And then we need to do some laser on this patient as well. Oh, by the way, so can you please put the oxygen level down to an FiO2 of 0.21 whilst we laser the lesion in the subglottis? And then we found an endoscopic cleft we wanted to repair, so it's going to take a long time. Oh, by the way, now we don't want the patient to have a tube in either, and we're going to take an hour to repair this type 2 laryngeal cleft endoscopically, and we're going to be manipulating, we're going to be lasering, we're going to be suturing, and you can't have an endotracheal tube, and we don't want to put a tracheostomy in either. You know, so what can we do? You know, we want to do a Hopkins rod. We want to do a flexible bronchoscope. One thing that we find helps us a lot is 2% lignocaine spray. Obviously, the anesthetist is going to use Tiva or sevoflurane, but you don't want to use sevoflurane too much because the whole theater gets sedated. Can you use Thrive? And I'm not going to talk more about Thrive because I think one of the other speakers is going to talk about high flow nasal oxygen. But does that work if you're going to laser? Dr. Anesthetist, please help me. And what if the patient is really obese? Is the Thrive really going to work for them? And then that's all the endoscopic stuff. And then what about the stuff we do open? So this is a criciotracheal resection in a newborn patient. Yeah, sure, we can put a tube into the cut end of the trachea. Or what about this patient? We're using a tube here, but this is a type 4 laryngeal cleft. The blue thing is a bougie in the esophagus. And you can see that the endotracheal tube is just sitting in the right main bronchus. Now, in this patient, who's going to manage that tube? Because the anesthetist, it probably has to be scrubbed into this operation to make sure the tube doesn't fall out of the right main bronchus. Well, we do this split from the carina up to the thyroid cartilage, and then raise some flaps and close the esophagus, and then close the trachea, and then close the anterior tracheal wall. Or we could do it like this, which is a criciotracheal separation. But fair enough, you've got a tube that can go into the cut end of the tracheostomy, of the trachea. But then often you don't have a good seal because you've got this opening on the posterior aspect of the trachea into the stomach in a type 4 laryngeal cleft. So we need the patient breathing spontaneously, and this is a live photograph of a type 4 laryngeal cleft, and this is the trachea that we've transected from the cricoid to open it up to enable us to close the esophagus and then close the trachea. Now that was the endotracheal tube that we'd inserted early on in the operation, which is now sitting in the esophagus, which we normally would have a tube sitting in here whilst we do this reconstruction. But you can see how it's just fallen into the esophagus, and we're using it now as a stent to close the esophagus. And that's the trachea with its cut end. And then there's open surgery in the distal trachea. Obviously, you can cheat and you can go on bypass, but you don't always have the option. So they're my problems for the anaesthetist. I'm hoping they'll come up with some solutions. Over to you, Dr. Baijal.
Dr. Baijal, please unmute yourself. Yeah, okay.
So my name is Rahul Baijal. I'm one of the pediatric cardiac anesthesiologists at Texas Children's, and I work frequently with Deepak, and I wanted to thank him for this opportunity again. So today we'll talk about the preoperative evaluation for airway surgery. After this talk, you should be able to identify high-risk patient comorbidities for airway surgery, identify indications to proceed immediately or urgently for these procedures, and finally, as a special consideration, identify high-risk children who may have an upper respiratory tract infection as they present for these procedures. So as with any preoperative evaluation, there should be a systematic analysis of patient comorbidities that place the child at risk for perioperative complications, and an analysis of surgical factors as well. So the approach that I take are: 1, evaluating the indications for the procedure, evaluating the urgency of the procedure, determining the chronicity of the disease process, and finally, performing a thorough history and physical exam as with any patient, and reviewing any laboratory and diagnostic studies. Special consideration should include the fasting status of these patients, and then the presence of an upper respiratory infection as well. So, as many of you know, it's important to determine the indication for the procedure, whether that procedure is a diagnostic or interventional procedure, such as an airway foreign body removal, tracheal dilation, or excision of an anatomic lesion. And so as it's just been mentioned, if the procedure is diagnostic, it's important to determine if the procedure is for a dynamic or anatomic assessment of the airway. As a dynamic assessment, as has just been mentioned, requires spontaneous ventilation to allow airway tone assessment. However, what's critical is that there are certain pathologies that I'll mention, such as pulmonary hypertension, myocardial dysfunction, and increased intracranial pressure that actually preclude dynamic airway assessment, as these patients invariably hypoventilate during the procedure and become hypercarbic. And that hypercarbia has deleterious downstream physiologic effects. So there really needs to be a frank discussion between the anesthesiologist and the otolaryngologist about the true need for spontaneous ventilation. I apologize. I'll have to restart just 1 second. There really needs to be a frank discussion between the anesthesiologist and the otolaryngologist about the true need for spontaneous ventilation and this dynamic airway assessment in these patients with pulmonary hypertension, myocardial dysfunction, and increased intracranial pressure. If the procedure is only for anatomic assessment, then either spontaneous or controlled ventilation may be used during the procedure. The urgency of the procedure is not only determined by the child's clinical status, but the etiology of the likely diagnosis. And that diagnosis is determined by not only the age of presentation, but also the chronicity of the presentation. In other words, has there been a rapid development of new symptoms, such as an airway foreign body or infectious etiology, or are the symptoms long-standing, such as a congenital or acquired condition, and has there been a significant change in the symptoms if the symptoms are long-standing? And in a few moments, I'll point out the symptoms that are concerning for me that determine if the procedure is more emergent and whether the child should proceed immediately to the operating room. The age of presentation is important because it may help differentiate the etiology. For example, laryngotracheal malaise, as you may know, and vocal cord paralysis usually present earlier in life, whereas airway foreign bodies, cyst or mass lesions may develop later in life. And certain infectious pathologies present within certain age groups. So for the general anesthesiologist in the audience, again, direct laryngoscopy and bronchoscopy is again performed for dynamic or anatomic airway assessment, with diagnostic evaluation often done for noisy breathing, likely stridor, but may also be performed for other symptoms such as hoarseness, chronic cough, recurrent lower airway infections, and choking. A DLNB may also be incorporated as part of a more comprehensive exam with a flexible fiber optic bronchoscopy and an EGD. And this aerodigestive exam is usually performed for chronic symptoms such as chronic cough, recurrent aspiration pneumonitis, recurrent pneumonias, and dysphagia. These aerodigestive exams are often elective procedures, and there's often no urgency or emergency to proceed to the operating room for these patients. And these patients really should be medically optimized based on the review of systems that, again, I'll mention in a few moments. So after determining the indications for the procedure, the urgency of the procedure, and the chronicity of the disease process, the preoperative evaluation should focus on patient comorbidities, including birth history, previous hospitalizations and procedures, and a review of systems. So birth history should focus on maturity, whether that infant was term or preterm. Preterm infants less than 37 weeks gestational age are at risk for postoperative apnea, periodic breathing, and bradycardia for up to 24 hours following the procedure, until 50 to 60 weeks post-conceptual age. And these preterm infants should be admitted for overnight observation for a 24-hour apnea, bradycardia-free period. Term infants greater than 37 weeks gestational age are also at risk until 44 weeks and really should be admitted for overnight observation as well. So any elective procedure, particularly in a preterm infant, should be delayed until 50 to 60 weeks post-conceptual age, given this risk. Birth history should also focus on a congenital anomaly, whether there is congenital heart disease present and chronic lung disease present in a preterm infant. Approximately 25 to 30% of patients with congenital heart disease have associated congenital anomalies, including airway anomalies. And so it's important to evaluate for the presence of congenital heart disease in these patients presenting for airway procedures. So many children may be routinely discharged following a diagnostic airway procedure or a simple interventional procedure, such as retrieval of an airway foreign body. However, children with significant comorbidities may have an exaggerated response to the anesthetic with either prolonged sedation, hypoventilation, or hypoxemia, and may require an unanticipated admission or escalation in ventilatory support or oxygenation. So it's critical to review the response to previous anesthetics and procedures to determine if that patient has had a previous unanticipated admission or an escalation of care. It's also important to determine how supplemental support was provided during the procedure, whether that was through passive oxygenation, intermittent intubation, or Thrive, and that may prevent an unanticipated admission or an escalation of care. And if a child has a history of subglottic stenosis, it's important to determine the size of that subglottic airway, particularly if endotracheal tube sizing was performed. So review of systems should focus on these particular pathologies. Is there congenital heart disease present? And if it's present, what is the underlying lesion? Is it repaired or unrepaired? And how well clinically compensated is that child with congenital heart disease? Particularly important, is there a history of myocardial dysfunction on arrhythmias, on echocardiography, or an EKG? Preterm infants may develop chronic lung disease, and it's important to determine the therapy of these infants with chronic lung disease, particularly are they on diuretic therapy or oxygenation or ventilatory support. These infants may be at increased risk for postoperative escalation and unanticipated admission, and more importantly, may be at risk for activation of airway reflexes with an airway procedure, resulting in bronchospasm, laryngospasm, and hypoxemia. Children with pulmonary hypertension, as I've mentioned previously, may not tolerate spontaneous ventilation during dynamic airway assessment. And again, there needs to be a frank discussion about the need for a dynamic airway assessment in these patients. Does the child have a history of difficult ventilation and intubation? And it's important to note that a previous history does not predict future difficult ventilation or intubation, or vice versa, as a child's airway is dynamic with pediatric airway dimensions changing with age. Is there an associated syndrome or craniofacial abnormality that may increase the risk of obstruction, particularly during induction of anesthesia or the procedure itself? Children with hypotonia may have an increased risk of obstruction as well, and particularly have an exaggerated response to the anesthetic or sedative, and may potentially require, again, an unanticipated admission or an escalation of care. And finally, is there a history of a bleeding diathesis that requires a further laboratory examination, or is the child on an anticoagulant that increases the risk of bleeding during the procedure? So, high-risk children presenting for airway surgery include preterm infants less than 50 to 60 weeks post-conceptual age, those less than 1 year of age, those undergoing an emergency procedure, be avoided in these patients. So physical exam should focus on pulmonary auscultation, cardiac auscultation. Gross motor tone, again, may reveal hypotonia, for example, syndrome such as Down syndrome, which again may increase the risk of airway obstruction. And the easy way to determine hypotonia is to determine if that child is meeting gross motor milestones. Are they sitting up? Are they crawling? Are they walking? Are they running? Obesity and failure to thrive are also risk factors for airway obstruction. And an airway exam should be focused, determining the presence of a craniofacial abnormality, presence of a large tongue or soft tissue inside the oropharynx, and the presence of a high arch palate. Even in an uncooperative child, airway assessment from the front and side can detect most potentially difficult intubations by evaluating for micrognathia, retrognathia, and mid-face hypoplasia. A high arch palate in association with a long, narrow mouth may also limit oropharyngeal volume for laryngoscopy. And so as a review for the general anesthesiologist in the audience, these images depict craniofacial abnormalities that may quickly be determined from a front and side exam. So on the left, you have a child with mid-face hypoplasia, with maxillary and zygomatic hypoplasia, with essentially a squished face and wide-spaced eyes. On the right, you have a patient with Pierre-Robin sequence, which you can clearly see with micrognathia and retrognathia as well. So pulmonary exam should focus on the presence of cyanosis or hypoxemia. What's the respiratory effort of the patient? Are they dyspneic? Is there noisy breathing with hoarseness, stridor, or a barking cough or voice changes present? Drooling may indicate significant pathology, as that child may be unable to handle airway secretions secondary to respiratory effort, airway tone, or an altered mental status. Is there torticollis? Positional changes also may indicate significant pathology. Is that child having to sit up? Are they lying supine? Are they lying prone? Are they lying on their side to achieve a position to relieve airway obstruction or improve airway tone? Again, that change in position may be helpful during induction of anesthesia, as that position will relieve airway obstruction during the actual induction. And finally, are there signs of airway obstruction with the presence of suprasternal, intercostal, or substernal retractions that also may indicate impending respiratory failure? Is the child febrile? Do they subjectively appear toxic versus non-toxic? And are there signs of a systemic process with tachycardia and hypotension? So in my opinion, these patients should actually proceed emergently to the operating room because of impending respiratory failure or airway obstruction. So a child with cyanosis or hypoxemia, one with respiratory distress with signs of airway obstruction and or positional changes, and one who appears toxic. Again, for these children, you can avoid a more thorough workup with history, physical exam, and a diagnostic and laboratory evaluation, given these impending clinical signs that may indicate respiratory failure or airway obstruction. Other questions that come up are regarding preoperative medication continuation. Really, all medication should be continued through the perioperative period, including ACE inhibitors and diuretic therapy. There are no specific guidelines that exist for discontinuation of antithrombotic medications for elective surgery in children. Of note, low-dose aspirin is not a contraindication for simple procedures, but for major procedures, there really needs to be a discussion with the cardiologist, the anesthesiologist, and the otolaryngologist regarding the bleeding risk from the procedure. So as a review, fasting guidelines include 8 hours for heavy meals, 6 hours for light meals, 6 hours for formula, 4 hours for breast milk, and 1 to 2 hours for clear liquids. Of note, the risk of aspiration pneumonitis with a full stomach often confounds clinical decision-making, particularly in the setting of more emergent procedures like an airway foreign body or infectious etiology. But the risk of morbidity for pediatric aspiration pneumonitis is low, about 0.01 to 0.05%. So a child with impending respiratory failure or airway obstruction should really proceed emergently to the operating room, given this low risk. Other children, however, should follow routine fasting guidelines. So as you may know, upper respiratory tract infections likely are the common cold, but may also include sinusitis and laryngopharyngitis, very rarely epiglottitis, and occasionally croup, tracheitis, and pneumonia. Most children have 6 to 8 upper respiratory tract infections per year, many of which are self-limiting, of about 7 to 10 days duration. Any upper respiratory tract infection increases airway hyperreactivity for 2 to 8 weeks, increasing the risk of a perioperative bronchospasm and laryngospasm. There is no diagnostic workup, including CBC or other acute phase reactant, that are valued of an upper respiratory tract infection or a perioperative complication risk. Of note, total intravenous anesthetics versus volatile anesthetics may actually decrease the risk of airway hyperreactivity in these patients. So one of the most frequent questions is, can I proceed with this procedure with this child who has an upper respiratory tract infection? And there are really two components to this question, the clinical and social component. However, any child with the following symptoms, the procedure should really be postponed ideally for 2 weeks. A child with purulent secretions, one who's febrile, a child with lower respiratory symptoms on pulmonary auscultation, a procedure that's going to require an endotracheal tube, as more invasive procedures are an independent risk factor for perioperative respiratory complications. Children who require an ET tube with an upper respiratory tract infection may have a complication risk of about 40%, with an LMA of about 25%, and even with a face mask of about 10%. Young children less than 3 years of age, those who have a history of prematurity, those who have an exposure to parental smoking, and a history of reactive airway disease. Particularly important for us, any child undergoing an airway procedure with these symptoms should again be delayed for 2 weeks as well. The other question that comes up is, what do I actually need to screen for these patients? Routine laboratory screening is not indicated in a child with negative history or physical examination, as it does not deliver any additional information from a thorough history and physical exam to rule out comorbidities. Of note, the positive predictive value of standardized
Yeah, Dr. Rahul, we lost your voice.
screenings. Hold on just 1 second.
Yeah. Just can you repeat that slide?
Can you hear me now?
Yeah, perfect now. Can you repeat the slide,
Okay.
please? Yeah, okay.
Sure. What I was saying was, the other question that comes up is, what sort of screening do I need to do for these patients? Routine laboratory screening is not indicated in children with a negative history or physical exam, as it does not provide any additional information than a thorough history and physical exam. The positive predictive value of standardized bleeding history is actually higher than routine screening from PT, PTT, and platelets. And actually, an abnormal PT and PTT may occur in about 15% of all routine screenings. Additionally, routine diagnostic screening, for example, with an EKG or chest X-ray, is also not indicated with a negative history or physical exam. And that's all I have for you. Thank you so much.
Thank you very much for your wonderful talk. At this time, I think we'll just get a few reactions from a couple of our panelists. And any anesthetists in the audience, please feel free to show of hands so that you can ask or comment on anything that you want to add extra, or there's a different way of what you're doing. So Deepak, can we ask, get your reactions? He's part of the team, so this is probably the routine thing that you do.
So thanks, Rahul. Just to let the audience know, Rahul leads our Airway program. He's my go-to guy. We are a team of like close to 100 pediatric anesthesiologists in our hospital. So it's a big team. So Rahul helps in standardizing care and making sure everyone is on the same board. Saying that, Rahul, can you tell us a little bit more about, say, when a patient is coming into the room, what are the things which you set up as a preparation for that procedure? So when it is an emergency, what are the different things you will set up in the room? And what are the things you, between you and the ENT, what are the things you will communicate so that both are on the same page?
Deepak, I think it goes back to the initial question of why are we doing this procedure? We know that the procedure is emergent, probably for a change in clinical symptoms or for acute symptoms. But really the question is, why are we doing this procedure? Again, is it for dynamic assessment, anatomic assessment, or for an interventional procedure? In that instance, from my perspective, that's a very important discussion that I have with a laryngologist is, again, why are we doing this procedure? If it is for dynamic airway assessment, our practice at Texas Children's is to maintain oxygenation or ventilation either through one of two ways: directly through the bronchoscope. So our ENT colleagues will have that set up in the room prior to them coming into the room. I think it's critical to have that equipment established prior to bringing the patient into the room. The other thing that we'll have, if there's a history of difficult intubation or ventilation, is any additional airway equipment that we may need, whether that's video laryngoscope, such as a CMAT or a glide scope, or even a fiber optic bronchoscope, or any additional LMAs that may assist with intubating as well. So those are the things that we consider here.
Yeah, thanks.
Yeah, Sohit, any comment? Sorry, Deepak, you need to say something?
No, that's it.
Sohit, any comments from your side?
Yeah, that was a great talk. I think that gives us a little bit of peek of what goes on at Texas Children. I think it's pertinent to, if you are running an airway program, to have actually a core group of anesthesiologists which are taking care of these kids. Anesthesia and pediatric airway is essentially an art, and you really need to have a hold on that art. So a couple of things which we do in our airway program is, number one, we have a core group of anesthesiologists who are going to take care of all these kiddos, right from endoscopic airway procedures to open airway procedures. They're actually a part of our aerodigestive program itself. So they'll attend airway conferences in which we usually discuss our open airway procedures, so they exactly know what's coming up in the next month or so. And most importantly, it's the communication between the surgeon and the anesthesiologist, which is really important. So we have a pre-induction where we essentially go through the whole procedure with the anesthesia team before the patient is actually wheeled into the room. So we essentially do a timeout outside the OR and then a perspective. So yeah, I think that was great, and all these cases are actually seen by anesthesiologists a day before or a couple of days before the procedure as well, as an outpatient appointment. So that's a separate appointment for all these complex patients. So just a little bit of things what we do in Iowa.
Thank you. Can you unmute Dr. Mogira, please? Dr. Mogira Siddiqui, welcome. He's joined us from Aga Khan University in Karachi. I've had the pleasure of being there in 2008 for the Pakistan ENT conference, and I can tell you we had the most wonderful time there. I've had the pleasure of visiting his institution, and he's been a pioneer in pediatric airway surgeries in Pakistan. Dr. Mogira, do you have any comments?
Thank you very much, first of all. I hope you can hear me, all of you.
Very well.
Well, thank you. So it's a pleasure being here in this meeting, and I have good presentation, and I've heard you very well said. My one comment that I want to make is most of those airway issues we deal with emergencies. When there are planned procedures, that's all right. You can go look for your go-to guy. You can look for your favorite anesthetist, who's the best in the field, and then you can plan things out. For me, it's very important, and I don't know if in India and in our part of the world is the same thing here, that we do not have specialized structure of the hospital where you have very, very super specialized people dealing with those emergencies on a daily basis. So for me, I would always look at my list and sometimes look at the procedure I'm doing and look at the anesthetist. Who's the one who's going to be in the room? Sometimes it's a pleasure. Sometimes I say in my heart, disaster. So you have to get to know your anesthetist. I know they're good anesthetists, fine. But you need to get the liaison well. And you need to know who are the people who will best suit for this procedure. So that's my one comment. And that's what probably that other people are saying is that you need to get super specialized people. Point number two is your gadgets. I agree. The only problem is when I've got a case with the suspected subglottic stenosis, and I would like to put my scope in for maybe 10 seconds and look down the airway up to the carina, and my anesthetist tells me, oh no, I can't give you the patient in a paralyzed mode, without a paralyzed mode. And then that's a problem, because we are not on the same page. I want to do a dynamic assessment, and he is not comfortable saying the lungs would not allow me to give you the patient without sedating and getting the control over it. So I agree. And what you're saying is we need to be on the same page. We need to have the right person sitting there. Sometimes it's not possible. Then you have to make some, exception, and then you have to go with the mindset that you have. And that sometimes creates problems. So that's my short comment. Thank you very much.
Welcome. We have a feedback form which will be, you need to fill up, because we want to know how much this kind of programs are helping you. And we have Dr. Gautham from Guwahati, who in the recent past has been pioneering an airway center in Guwahati. Sir, can you tell us, any comments? If there are no comments, we're going to have some more time for discussions. Is there special, you have a core team in your place? What do you do?
Yeah, thank you, Dr. Raman, for actually including me in this elite panel. We are a very small group doing airway work, and as we are not a very specialized sort of thing, that we are not doing only airway like most of the big centers, and our volume is less. So it's a challenge for us to train and get in sync with our anesthetists, because they are doing many other things apart from airway, and to get them sort of tuned to working with the airway. And as the experts have spoken, what we generally do is for every case we sit down, we have a discussion about how to go about, and we tell them what we want to do, and whether it's a dynamic assessment or whether we are going, how much roughly time we are going to take, and things like that. And of course, we also discuss about what problems we might face, and accordingly, what are the steps we are going to take. And I always insist on my anesthetists actually, so to get used to using equipments that they are not very familiar with, which they might have to use in a tricky situation, because there's no point keeping those instruments to be used only in that situation. So I think it's better to getting used to all those things. So it's better for, a lot of cooperation, but we are learning, listening to you, we are learning from you. Thank you.
Thank you. So that we don't infringe on the time of the other speakers, I'll go ahead, but please, with a show of hands, all of you are part of the panel, all of you can share your experiences. And the next speaker is Dr. Jayashree, who's the chairman of the Anaesthesia group in the Manipal hospitals. She has been with us almost for close to 2 decades when we took our baby steps. And incidentally, we run a children's airway and swallowing center, which is doing charitable surgeries. And in India, that's the only way to, I think, reach, to enable our skills to benefit children from across the sections of society. And I must again thank Deepak, Kishore, Shyan, who've been coming to us every 2 years, training other ENT surgeons, and we've also been training. And without much ado, may I ask Dr. Jayashree to talk about the challenges in the pediatric airway, anesthetic challenges. And we have time for an open house later, and all of you can put your points in, and we'll be very happy to get your reactions. Dr. Jayashree.
Thank you, Dr. Raman, for giving me this opportunity to share my experience with the august audience here. And I would like to just being there with you and with the Airway team for so many years, as we have improvised a lot, and then we have gone ahead during your baby steps. We have also taken our baby steps, and we have learned a lot together. So this is basically the anesthetic challenge in surgery for pediatric airway surgeries. This what is a topic, and
Yeah, go down. You will see those direction arrows. You can forward the slide. Down on the left side, you will see those arrows.
Wait a minute. I'll have to put it on this thing, I think.
Slide it left.
Really?
Slide it left. Move the cursor here. Why is it not moving? Not that.
Sorry for the.
You can arrow. You can use arrows otherwise. Try arrows, sir.
No.
Arrows not moving.
It was moving earlier when we tried. Okay, I'll just
click again. Click on that only. Right click.
I'll stop sharing and start again.
Yeah, please.
Okay, while that's going on, I think we need to tell you our plans. We are expanding our group to include all the countries in this region. And we have Dr. Yogesh from Nepal, Dr. Yasavardhane from Sri Lanka. We'll get somebody from Bangladesh also.
Yeah. So with this, I would like to welcome Dr. Venkatagiri, the President-elect of Indian Society of Anesthesiology.
Welcome, sir.
And also like to welcome Dr. Chidanand, a senior consultant who was there earlier at BGS Global Hospital and Center Hospital. He is in Pune right now, Pune National Hospital. Welcome, sir, both of you.
Thank you. Do left click. Right click, yeah. Doesn't matter. That's all right.
No, but it's not.
Previous is there, no? Previous. You go next one.
Yeah, it's okay.
Okay. Airway surgeries itself is a big challenge, and when you add pediatric anesthesia along with that, it becomes a lot more complicated. Pediatric anesthesia particularly has a little variation from the routine anesthesia because of its anatomical variations, the physiological differences, and the pathological issues of the situation. Of course, the list of anatomical variation is available in most of the textbooks, of which the large head in the tongue and the narrow subglottic region, and these are the most important part of it, which you should remember in our mind. The physiological differences are primarily, which bother us, is the low fixed tide volume, where the volume depends on the diaphragmatic breathing, and fewer muscle cells, and higher metabolic needs, and narrow margin of safety, which leads to hypoxia and desaturation. And it's more sensitive, most of the kids are sensitive to liquid solid irritants as against inhalational gas. And as Rahul has already insisted that infants less than 60 weeks of post-conceptional age are at the higher risk of developing apnea, especially when they are born premature in the post-operative period. Now, this prematurity has its own things, which particularly when it leads with the immature nervous system, also the liver, as far as the digestion. So, and many of these children who come with a swallowing difficulty and they have failure to thrive, they have a new set of things added. There will be more secretions, the more airway irritability, laryngospasm, risk of wheezing and airway edema. And the children are uncooperative, that can add on to the struggle, fight, and the excessive stress and metabolic rate. These children get easily sedated because of immature neurons and because of less myelination, and then they lead to higher risk of respiratory depression. And maintaining them on spontaneous becomes a little more challenging. Again, the apnea of prematurity is more possible, and that hypoxia, hypercarbia, sleep disorders, they are all another reason which cause apnea, causes in hypoxia, bradycardia, and worse hypoxia are known to occur. Now, when they come for surgery, the airway scenarios may be of different nature, particularly in a normal airway, which is with a normal anatomy. It can have a planned surgery or emergency surgery. The same thing can get impaired airway due to added on infection or allergic swelling, trauma, burns, and it can become definitely more of an emergency situation. And the abnormal airway, if it is because of congenital anomaly, we can plan the situation and then go ahead with that. Now, airway surgery challenges are a big tug of war between the surgeon and anesthetist, is because of the shared area of operation and limited access to airway. And high level of understanding is most important, as it's been insisted by all the surgeons and the anesthetists, is to have a best understanding between the anesthetic and surgical team. And there is a need of unobstructed immobile operative field. And this also should provide adequate oxygenation and carbon dioxide elimination. And then finally, a rapid return of consciousness and airway reflexes. Now, safety requirements that is required is basically the surgical and anesthetic equipments that we have to be do thorough knowledge of the anatomy, physiology, and pathology of every case. And then we have to have the also backup of tertiary care center or ICU, pediatric ICU for managing these children post-operatively, and then efficient communication between the entire treating team involving surgeon, anesthetist, pediatrician, and intensivist is most important. The common pathological conditions which needs surgery are like epiglottic cysts and valvular cysts and laryngeal tumors like webs, tracheolaryngomalacia, and stenotic areas in the tracheolaryngeal area, and vocal cord dysfunction cysts. And we of late we've been doing some for exit procedures as well. Now, procedures on airway can vary from simple diagnostic scopy to a complex laryngeotracheal surgery. And these therapeutic procedures of excision of lesions, laser evaporations, and division of webs, removal of foreign body, stenting and dilatation of the stenotic lesions, and correction of clefts, and aeplasty for laryngomalacia. And of course, the exit procedure, which we have planned. The anesthetic management involves a pre-operative evaluation, which I'm not going to go into the detail because Rahul has already given a detailed discussion on that. But where I'm talking about is the anesthetic room preparation, the monitoring that is required, the induction, the maintenance and anesthesia, analgesia part of it, and post-operative care. Now, airway management
from the train, I think we see this. We see this.
Pardon?
I think somebody can mute their mic.
Oh, sorry. The airway manifestation can be
Cold.
upper airway obstructions, which could be partial, which may be causing stridor, which could be monophasic or biphasic, or it could be complete obstruction, and that can be that will have to be definitely with the tracheostomy because that could have come as an emergency. And there can be dynamic respiratory distresses, which may be because of the tracheobronchomalacia. And we also have to know about the cardiac status of whether there was any cyanotic spells, and coughing and wheezing and life-threatening hypoxia, which might have occurred because of the cardiopulmonary associated problems. The most important is the feeding difficulties, which may lead to aspirations and recurrent chest infection. And these children may come with this failure to thrive. Now, as I said, absolutely there is no need for any investigations for these children if there is no history of relevant history. And therefore, these are all which are just for the sake of, in case there is a relevant history, then we will have to, if the foreign body or anything of that sort, or if there is a congenital anomaly, then we require the things like X-rays, assessment with CT or MRI, sleep studies if there is a dynamic obstruction occurring during sleep, nasal endoscopy if there is any obstruction there. Blood investigation very rarely are required unless they are on medications or if they are having anticoagulants, and just to make sure they are all well under control. Of late, we have been doing a lot on the ultrasound assessment. This is particularly what we are doing is in just in the pre-op area, we would like to know exactly the way it is obstructing and how it is causing the dynamics of the obstruction, the location of obstruction, and that gives us, it has been helping us to plan our strategy well. Now, monitoring as far as during these cases are extremely important, because since routine ECG monitoring to make sure that it's all safe, and the respiration very often we monitor with end-tidal oxygen and the carbon dioxide, which cannot be done in spontaneously breathing patients. So we use this plethysmographic respiratory monitor on the ECG leads. I always tend, blood pressure is just to make sure that adequate volume is maintained, and the saturation probe, I always prefer to have 2 saturation probes, because when one malfunctioning at the right moment can give you a jitters. And end-tidal carbon dioxide is used only whenever we are using a controlled ventilation or the patient is on when it is intubated. Anesthetic gas monitoring is another one, which is a tool which is very important when we are doing laser surgeries, particularly when we want to keep the oxygen levels at a lower level, and the temperature monitoring to make sure the child is not cold, and then all these things can cause respiratory depression. I have used entropy in certain cases where it is a long duration, and then if there is just to make sure that an adequate depth of anesthesia is maintained and it's not too deep, not too light. Now, anesthetic room preparation is again very important in this particular thing. We have to have experienced assistant in case of catastrophes to help us with the requirement of all the equipments that we need from our side. The local anesthetic sprays, gels, atomizers, difficult airway equipments, the face mask, laryngeal mask, oronasal airways, stillets, guide wires, bougies, suction apparatus separately for anesthetic team, and laryngoscopes, particularly of late. Videoscope has been extremely useful, and we have always had the videoscope with us, and always a backup of surgical airway, cricothyroidectomy, and the tracheostomy should be available. So these are the various equipments that we usually require. As far as the pre-medication is concerned, most important pre-medication that I always use without fail is anticholinergic. That has to be given, because any bit of secretions or this thing can cause irritability of the airway, and then that can cause a series of hypoxia and other things. Sedative almost always avoided, because it will depress the ventilation and respiration. Most important is how to deal with the child and assure the child till the child goes under. You can just have a hold the child and then induce the child, and once the child goes in, then we can do. Pre-operative bronchodilator nebulization will definitely help when the child is with the parents, and steroid and hydrocortisone dexamethasone always used as a handy tool. Now, as Sean said, the ideal situation that he wants is a spontaneously breathing child, which is with a well anesthetized airway, which should be tubeless, maintaining good oxygen and carbon dioxide level, and presence of well-trained, experienced persons around. Most often, this is it's a very fine balancing act, and the challenges are purely because of the pre-existing obstruction, difficulty in maintaining steady spontaneous ventilation. Now, too deep levels can cause apnea and loss of airway and desaturation, or too light planes cause coughing, bronchospasm, and desaturation. The airway bleeding is another problem in there if any handling of the airway is done, and that can trigger obstruction, spasm, and then desaturation. Now, airway obstructions, because of the bleeding, the dislodgement of, if there is a foreign body, edema of the airway, and if it is traumatic intervention. And the most important other problem is the gastric distension, which can occur if the high flows of gases are used, and that can compromise our respiration. Now, most important techniques that we use for airway anesthesia is spontaneously breathing patient with tropical anesthesia. This is used for primarily endoscopic work, with or without sedation to see the dynamics of the child. This is a flexible scopes that are used. The second state is the general anesthesia with spontaneous respiration. And the general anesthesia was a controlled respiration with microlaryngeal tubes or tracheostomy. And general anesthesia with the rigid bronchoscopy, where you can control ventilation. And low frequency jet ventilation or high frequency jet ventilations are used, but of late we are not using that much. Now, most commonly used technique for all the dynamic assessments and the procedures on the glottis, we use this general anesthesia spontaneous ventilation without the tube. So basically this is fairly safe. Maintenance of upper airway patency is maintained and dynamics can be assessed well. The oxygenation are well maintained and less chance of pneumothorax and dislodgements of foreign bodies because of the IPPV is not there. And it's a clutterless operative field for the surgeon to go ahead. But the limitations are child can cough and laryngospasm can occur. It can be a moving target for lasers and the risk of aspiration is potentially there, though it's much less with children. And difficult to maintain in prolonged surgeries, and particularly with children with the cardiac and pulmonary issues. And the other most important is unable to assess end-tidal carbon dioxide levels and the adequacy of ventilation. But general anesthesia paralyzed ventilation is used primarily when the child comes with a pre-existing tracheostomy and a definitive surgery is already planned without assessment initially. This is simple with a no coughing, optimal intubating condition, motionless target for laser surgeries, and it prevents atelectasis and less chance of aspiration. However, the limitation is upper airway soft tissue collapse can occur if intubation it turns out to be difficult, and rapid desaturations can occur when there is no tube, and may lose ability to ventilate and gastric distension when you ventilate with a high pressure ventilation, and restrictive operative field for the surgeon. Now, induction is primarily, we should always have is inhalational, and IV access should be there before induction. So in which case we can give an anti-sialogogue to before to start the case. And inhalational induction is most favored, and the sevoflurane is the most preferred agent, which causes less airway irritation. The general IV agents can be primarily could be propofol, low loads of propofol without stopping ventilation. Of course, before starting any case, we should have in the back of mind all the difficult airway algorithms, so that we don't fumble at that particular point of time. And this is available in most of the textbooks. I'm not going to go into the details of it. Only we should try and avoid a situation called cannot intubate, cannot ventilate the thing, and the child is already paralyzed. This is going to be a disaster, and will require a surgical interference for an emergency tracheostomy or a cricothyrotomy. So this should be tried and avoid. At any time, calling help is the most important thing. Now, maintenance of the anesthesia depends on the type of procedure that is being planned. For every dynamic study, the gold standard is the spontaneous ventilation, and then only we can do the dynamics can do. The tubeless field is most preferred, then assisted, and that can be maintained along with an assisted intermittent assisted ventilation or insufflation or intermittent apnea technique or jet ventilation. What we normally do is in our setup is insufflation technique. Now, deep inhalation of sevoflurane is basically because there is a lot of air dilution when the tube is not inside, and then therefore you may require a higher MAC of sevoflurane, and it can be added on with IV propofol or dexmedetomidine boluses or infusion, which is IV thing, and then that maintains the levels much better. And positive pressure ventilation for rigid bronchoscopy or microlaryngeal tube is the next way of maintaining. If there is a definitive procedure on the supraglottic area. And always there is a backup of surgical airway. And if there is a surgical airway, if there is dynamic study, we may still have to do a spontaneous ventilation to study the dynamics. The commonly used drugs that are mostly atropine or glycopyrrolate for anti-sialogogue. Most important part of the anesthesia is the topical spray of lidocaine, and depending on the size of the age of the child, I use either 2%, 4%, or 10%. Adults 10%, for 2 and 4% for the children. And propofol, we can use it intermittently or as an infusion. Dexmedetomidine, and always add on some steroid, dexamethasone, hydrocortisone, and nebulization epinephrine, which can be also given preoperatively, and derifine is a bronchodilator. Most of the supraglottic pathology, it's very important to access the airway with spontaneously breathing, breathing child, because very often all these cysts and there can be really floppy and they can be falling on the airway. And if the child is breathing spontaneously, it is easier to locate the glottic aperture. And then what I do basically is use a lot of local anesthetic sprays before I put in the laryngoscope, so that the child doesn't buck and it becomes much more simpler to do the procedure. They will accept the tube much easily. And then if there is a very small patent airway, then I usually put a guide wire first and then thread the tube over it. Sometimes flexible bronchoscopy, videoscopy have been always very helpful. And it depends on the size of the tumor, and it's been always been in any life-threatening conditions, always at the backup of surgical airway is necessary. As far as the glottic or subglottic pathology is concerned, tubeless unobstructed field is the gold standard. And I have already enumerated the advantages and disadvantages earlier. As I said, less manipulation of the airway, facilitates larger instrument usage, and muscle relaxants are not used, and very little carbon dioxide accumulation occurs if the spontaneity is maintained, and minimal risk of pneumothorax. While the flip side, we have no definite airway control and difficult to measure entirely. But at that, if you have a good understanding with the surgeon, it's at any given situation, you should be able to put in a tube through their scope and then ventilate for a while, and then the situation can be kept under control. Now, this is the lighter veins. Particularly this, we use this particular procedure of spontaneous tubeless technique for laryngomyelitias, vocal nodules, subglottic cysts, and respiratory papillomatosis, subglottic hemangiomas. However, if there is a stenotic lesions, they are life-threatening and it may need tracheostomy. And if it is, that have to be kept in mind. This is the insufflation technique that we use. Here I have been using endotracheal tube itself from the nose, and it is passed through the nasopharynx, and it is placed in front of the glottis, but not inside the glottis, so that the child is able to get the anesthetic gas. Of course, there is going to be a lot of pollution, environmental pollution because of the anesthetic gases, but I always supplement with the IV agents. This is where the endotracheal tube comes out and it's placed in front of the glottis. This is for a laryngomalacia with the pre-op substernal, then a short AE fold which is divided. That's being done with the cobblator. And this is post-operative and there is not much of thing. General anesthesia with IV, this positive pressure ventilation is preferred in procedure using rigid ventilating scope, and that's used for this is actually web, laryngeal web, which was dissected earlier. And then we use this bronchoscope, this thing for foreign bodies, and cases of pre-existing tracheostomy where we can use positive pressure ventilation. Laser surgery is going to be another challenge in airway. Particularly, it can convert a bad situation to a worse situation and potential fire hazard. The types of endotracheal tube that we require is basically a metallic tube, which is not available. Very small tubes are not available in pediatric airway. So we have to use something like a wet cover or a protective taping. And most important in our monitor, we have to have minimize the FiO2 and avoid nitrous oxide, and FiO2 should be kept definitely below 30%. So whenever they use laser, we should be clear about having our FiO2 less than 30%. Of course, fire protocol should be always kept in mind. And the most important is to stop ventilation and disconnect circuit and extubate, so that the burns does not proceed to the distal airway. And then subsequently, once the fire is doused, we can again mask ventilate with oxygen and re-intubate and all the other things. With the laryngeal, we have to remove the debris and assess the damage of oropharynx waste, and then subsequently take a call depending on what is the situation. This use of analgesics in particularly in airway surgeries is most important. It cannot be trivialized, because most of the time we use an adequate amount of local anesthetic, topical anesthesia, and that takes care of a lot of analgesia. Non-respiratory depressant analgesic like paracetamol, ibuprofen can be used. Generally, I avoid using narcotics because that can suddenly stop, suppress the respiration in a particularly spontaneously breathing child, and that can cause again hypoxia and apneas. The post-operative care is most important after all this surgery is done, because these procedures can lead to bleeding, edema, and most of the time we, for a short while or at least depending on over 24 hours, we keep the children in the pediatric ICUs with the right posture, monitoring, and nebulization or oxygen supplement, and give adequate time for full recovery and availability. Emergency teams should be always available to do the thing. And depending on the symptom, we have to, because it is desaturation, stridor, obstruction, we should always have the suction and nebulizations, anti-edema measures, oxygen supplement, CPAPs, and re-intubation if required. The most important take-home message for anesthesia for airway surgery is aim to never lose control over airway. Always add anti-silogogue to control secretions. Always include a topical anesthetic spray to reduce irritability of the airway. Add steroids as anti-edema measures. Add bronchodilators to reduce airway spasms, and definitely have both pre-op and post-op nebulization. And finally, it is a high-grade balancing act, high level of cooperation between the treating teams, high degree of improvisation in airway access techniques and backups. Each case is a new challenge. Never hesitate to call for help, as they can be touch and go situations. Learning never ends. These are the few cases that we have done, which I just got a pictures of. It's a laryngeal papilloma before the excision and after excision. This is that same laryngeal web, which was at 1 month of age, and then at the 10 years of age, the same child had come for a check follow-up. This is before intubation, how that was covering the entire glottis before intubation, and after intubation, once that is moved, you have got a good glottis, but the cyst was sitting right on top of the thing. And of course, insertion of balloon and balloon dilatation, which most of you surgeons are aware of. Well, this is a wisdom of anesthesia. Thank you.
Thank you very much, Jayashree, for your comprehensive talk on the proper process of anesthesia that you need to go through for these airway surgeries. It's very challenging. And both Jayashree and I think I can speak on our behalf, we were self-trained, so to say, and our faculty, which comes from the best centers in the world, have found her a great asset. And whatever we've done today, I think more than 50%, I'd like to claim 50, but I think much more than 50% of what we've achieved is thanks to Dr. Jayashree and her team. And she's also been actively training the other anesthetists in the group, which is very nice of her. And like I said, all this is charitable. So they've taken time off from their earning time and helping us. I'm very grateful to this anesthetic team. And we have some excellent anesthetists in the panel. Dr. Anil Patil is here from the Royal Throat, Nose and Ear Hospital from London. He's going to add more value to what Dr. Rakesh Srivastav is going to present now. And we have Dr. Venkatagiri, President of the Indian Society of Anesthesiologists. And we've got Dr. Raj, who's going to come towards the end of the program. Shyan from CMC Vellore, who's going to just wind up a couple of very important things that he does in his place, some tips and tricks kind of a thing. And please be around, and please kindly fill up our feedback form to give you better programs in future, if this can be better, that is. The next speaker is Dr. Rakesh. He's going to talk about HFNC, a game changer in airway surgeries. And we can have the discussion later on what Jayashree has presented. And can we have Dr. Rakesh, please? Okay, I made a mistake. It is Anil Patel, not Patel. I'm sorry about that.
Good evening. Can you hear me?
Yeah, very well.
Yeah. Good evening and good morning to all of our US friends. I know there will be a lot of interest among the ENT surgeons on high flow nasal cannula and what I'm going to talk about. But I am prepared for all my questions, and to protect myself, I've called a bomber from UK. Dr. Anil Patel is here. So if I'm not able to answer your question, then he will take over. So I dedicate my presentation to my anesthetist. Sorry. To my anesthetist, Dr. Shishir Agarwal and Dr. Manu Pathak, and who are with me for last more than 10 years. And my mentor, Dr. Anil Patel. I read his article in 2015 when he first talked about the thrive and use of high flow in airway surgeries. And from 2016, my anesthetist, they have forced me to buy this high flow. Then I contacted Fisher and Paykel, and then finally I got this high flow in 2016. And since then, we have been using this high flow almost more than 150 procedures. Therapeutic and diagnostics both, and we are very happy to date. We have not encountered any of the complications with high flow. This is my meeting with Dr. Anil Patel in Laryngology meeting in June 2018. I attended his instructional course also. So that was my presentation initially on 16 cases of high flow, and now I have 2 publications on high flow, the use of high flow in various airway surgeries. Before understanding high flow, we have to know a few things like pre-oxygenation, apneic oxygenation, what is the mechanism of high flow, what are the indications of high flow and how it can improve my results, and what are the extended application we are using it in our airway practice. So we all know that cannot intubate and cannot ventilate situation is fewer than 1 in 5,000 routine general anesthetic procedures. An emergency surgical airway requirement is there in 1 in 50,000 cases. But the recent data which has come up is CICV in 20 institutes which has come up from Japan. The incidence is quite low. That is 0.003, almost 1 lakh of cases. There are 3 cases with the CICV situation. So healthy pre-oxygenated patient, the safe apnea time is up to 8 to 9 minutes compared to 1 minute if they are breathing the room air. So optimal time which we have to pre-oxygenate the patient is 3 minutes of a tidal volume breathing, that is normal respiratory pattern with a high FiO2 source, or 8 vital capacity breaths, maximum inhalation and maximum exhalation with a high FiO2 source in a cooperative patient. So that should be the goal of a pre-oxygenation. And a standard non-breather at 15 liter will deliver 60 to 70 liter of FiO2. And if we increase pressure, we can increase the FiO2 values to a maximum to 90 to 100%. So coming to the what is the safe apnea time, is a duration of time until critical arterial desaturation occurs following cessation of breathing. So that is when the saturation falls below 88 or 90% marks, that is the upper inflection point of oxyhemoglobin dissociation curve, beyond which further decrease will lead into rapid decline of oxygen concentration. So oxygen consumption during apnea is approximately 200 to 50 ml per minute. We all know, and one person is breathing 100% oxygen, this washes out to nitrogen, and which increase the lung capacity to 3 liters. But in healthy people under ideal circumstances, PO2 can be maintained up to 100 millimeter of mercury for up to 100 minutes. But the catch is it will cause hypercapnia and significant acidosis. So one, what Dr. Jayashree has said, we have to prepare, we have to not allow the patient to go for a respiratory acidosis. So there are few terms like no desat, that is the nasal oxygen during effort securing a tube. So during apnea phase, no room air or expired gas with the low oxygen enters the nasopharynx to dilute the 100% oxygen delivered through nasal prong. So if nasal cannula applied to a flow rate at 15 liter per minute during pre-oxygenation, once the apnea starts, it provides reservoir of 100% oxygen in the dead space, that is nasopharynx. So what are the factors that decrease the safe apnea time? There are various causes of it. Once we are not doing a inadequate pre-oxygenation, airway occlusion is there. There may be a decreased safe apnea time, pulmonary shunts, various cardiac causes, BMI is high, pregnancy, and small children. The small children, we all know the reasons are different. There are many anatomical reasons, there are many physiological reasons for decreased safe apnea time. So what is the physiology of apneic oxygenation, which most of our ENT colleagues, they must know about it before venturing for high flow. And most of our anesthetists, they know about it. So physiology of apnea is alveoli will continue to take up oxygen even without diaphragmatic movement or lung expansion. This is a concept which Dr. Anil Patel has used it, that in a healthy apneic patient, 200 to 250 ml per minute of oxygen will move from alveoli into the bloodstream, and only 8 to 20 ml per minute of carbon dioxide moves from alveoli during apnea, with the remainder being buffered in the bloodstream, giving a high water solubility of CO2. So there is a subatmospheric negative pressure at the alveolar level, which is known as aventilatory mass flow of oxygen, which is occurring from the dead space to the level of alveoli. So that is how it has been depicted here. There is a subatmospheric pressure at the alveolar level, and that causes the flow of gases from the dead space to the alveolar level. In healthy people under ideal circumstances, PO2 can be maintained. Sorry, this prerequisite for apneic ventilation is effective pre-oxygenation. That is what I have told you, that 3 minutes of minimum, ongoing provision of high flow oxygen, and maintenance of patent airway. So apart from this, there should not be any alveolar collapse at the peripheral level. So there are other techniques of apneic oxygenation like nasopharyngeal airway, laryngoscope, video laryngoscope, blade channel, which can be used. There are standard nasal cannula which can be used. But the problem with these techniques is it delivers a cold, dry air at low flow rates. As compared to high flow, it is a heated, humidified, high flow nasal cannula. So it delivers a oxygen at a humidified oxygen, and it doesn't cause irritation of the airway. It doesn't affect the motility of the cilia, and it causes less of irritation of the airway. So the OptiFlow, as it is called, it is a nasal high flow. It is manufactured by Fisher and Paykel, from where I have ordered it, then I got it, and with the aim to improve the patient tolerance. And that is how this machine looks like. But there are few newer changes in there. So this is a high flow machine. It's a simple machine with a blender here, and this you can connect with the central supply. Initially, we don't have the high flow this manometer, because India, we don't get this high flow manometer with a around pressure of up to 70 liters of oxygen you can generate. So initially we will be using 15 liter from the main supply of oxygen, and then 15 liter from the workstation. So we will be using it like that. But finally, after 3 months, we got the high flow manometer. And this is an instrument which I have been using it for adult laryngoscopy. That is a clean saucer laryngoscope, which we modified it. And with a for a surgery or all the benign lesions, we are not using any tube. In few cases, we use a tube, but most of the smaller procedures like 15 minutes and half an hour procedure on a safe patient, we use this type of laryngoscope, because this blocks the, once you block the glottis, then the use of high flow will not be there. So just to maintain the continuity of oxygen flow at the lower respiratory level, so we maintain with this fenestrated clean saucer laryngoscope. So what is the mechanism of high flow? It washes out the nasopharyngeal and pharyngeal dead space with 100% oxygen. It reduces the airway resistance and work of breathing by continuous and adequate flow during the time of surgery. It improves the lung compliance and airway conductance by providing humidified oxygen. And it is providing end descending pressure, which is very important because it increases the end expiratory volume and positive end expiratory pressure. So at a very high level of 60 liter of oxygen, it can generate a peak pressure of 7.4 milliliter. So it keeps the alveoli open, and that is how the 5 key mechanisms of high flow is there: CO2 clearance, positive airway pressure, maintenance oxygen, humidification, and patient comfort is there because of it is heated and humidified. So when a spontaneously breathing patient is there, the respiratory flow rate is 20 to 40 liters per minute. But once we are using a high flow at a rate which is higher than 40 liters, it can generate FiO2 of 100%. While the nasal cannula, it can flow rate of 2 to 4 minutes, which generate FiO2 of only 25 to 30%. Now, talking about high flow and without talking about this article, which changed my practice, that is, which was published in 2015 by Dr. Anil Patel, and he has used the term the transnasal humidified rapid insufflation ventilatory exchange. This technique that it maintains oxygen saturation for significant period of time after commencement of apnea in surgical patient. So in these cases, he used a relaxant with a high flow, and what his finding was that in a patient of a higher BMI, the median apnea time was 15 minutes, and no patient experienced arterial desaturation of less than 90%. And the interesting part is rate of increase in end tidal CO2 was very less, 0.15 kilopascals per minute. It combines the benefit of classical apneic oxygenation, and it supplies a continuous positive airway and gases exchange through dependent dead space flushing. And most of his patients, that is 25 patients he studied, and most of the patients are having Malampati grade 3 and with a BMI of more than 30 kg. That was also remarkable with and getting an apnea time of 14 minutes, mean apnea time. So the important aspect of Thrive or high flow is we have to know about a little bit about CO2 physiology during apnea. So because that is the only concern with rise of CO2 and respiratory acidosis, which may be one of the deadliest side effect of high flow, once you're not aware of it. So human body now produces 200 ml of CO2 per minute. And we, as I told you, the heat is highly soluble, and during apnea, 90% of CO2 remains in circulation and is redistributed throughout the body, whereas 10% enters the alveoli, resulting in uncompensated respiratory acidosis. So rate of rise of CO2 is possibility, leads into uncontrolled, deadliest cardiovascular complications, seizures, and arrhythmias. Adult patient, the average PCO2 is 1.12 millimeter per minute to 2.4 millimeter per minute. And with 45 minutes and 65 minutes of apnea, the highest CO2 measure recorded is 89 millimeter of mercury and 112 millimeter, which is quite high. While as compared to pediatric age group, the increase is slightly higher. In first minute, it is 12.2 millimeter of mercury, followed by 4.2 millimeter of mercury over next 4 minutes. So these values are very important once we are using high flow, because that is the only thing which I have been highlighting is hypercarbia and respiratory acidosis. This is another important paper which was published last year only, and we will not be able to explain it why there was not so much of CO2 rise when we are using a high flow vessel. So their observation, it was a physiological study to determine the mechanism of CO2 clearance during apnea when using Thrive. So it has been observed that enhanced CO2 clearance observed under apneic condition with Thrive as compared with classical apneic oxygenation. But the explanation which has been given is because of the interaction of gas flow from cardiogenic oxidation and high flow. So what is cardiogenic oxidation? It refers to changes in airway gas flow and pressure that are synchronous with cardiac cycle. And it is believed that it arises from the movement of blood in pulmonary capillaries. So the blood in the pulmonary capillary, which moves with the cardiogenic oxygenation, it causes compression and expansion of the smaller airway at the alveoli, at the level of alveoli, and that is how the CO2 moves out from the carina up to upwards in the airway. So that was an explanation, because that the rapid rise is not there while using a high flow nasal cannula. So cardiogenic oxidation is prevents the rise of CO2 because of the vibration at the airflow at the level of the pulmonary capillaries. So pediatric airway, Dr. Jayashree has already told about what is the difference, and it has been studied in pediatric airway also, the Thrive, and it is published from Australia only. It was a RCT done in children of 48 healthy cases has been studied, and it has been found that in an infant of 0 to 6 months, while using a Thrive, it is almost 3 minutes we can get time as compared to the control group. So while using a Thrive, the duration of apnea, we are getting it with using a Thrive is higher as compared to the so this is how we are also doing a study on various procedures. We are observing that how many times we have to intubate the patient, or we have to use a bag mask while using a Thrive. So the duration, if you observe it, it is higher as the age grows, but the catch point is less than 1 year. It is still the difference is not, though it is double the average time length as compared to the control, but still it is a very less once we are doing a foreign bodies or very small procedures of few minutes procedure. So on my last presentation, I showed you few of my foreign bodies which I be using a Thrive and not using a ventilating bronchoscope, just taking out the foreign body with the optical forceps. And the other important thing is rate of CO2 changes in control and Thrive is almost the same. So it is 2.4 millimeter of mercury per minute in both the control and the patient with the Thrive, using a Thrive. So clinical application, in most of the airway procedure, we can use it. What are the indications of high FiO2? We all know most of the airway procedure where you think that there are chances that patient saturation is going to fall, then you can use a high flow nasal cannula. What are the contraindications of high flow? Partial nasal obstruction, disrupted airway, epistaxis, need for laser or diathermy in proximity because there is a potential risk of fire of using a high flow. Contagious pulmonary infection, the chances of infection spreading to the lower airway. Nasal infection, contraindication in prior bleomycin chemotherapy because of toxicity has been increased with using a high flow oxygen. So how to begin high flow? Airway should be clear, maintain semi-sitting position. We normally raise the patient head end to 20 to 30 degree. And then we continue with the high flow for 10 to 15 minutes. Diameter of nasal cannula should be half of the nostril diameter. And in infants, we use a higher level. And in children, we use a 1 liter per kg. And try to maintain saturation at 95 to 98%. So this was our article which was published in 2019 on 16 cases of varied patient age group. And we have excluded the microlaryngeal procedure, but most of the airway, all the airway cases we have included. This is on 16 patients. Now, other thing which normally common term which has been used is the strive HI. Strive HI is spontaneous aspiration using intravenous anesthesia and high flow nasal oxygen without using a relaxant. So every center has got its own merits of how to use this high flow. So what normally we follow it like this. So that is how we 10 to 15 minutes we start with high flow, then local anesthetic spray. Then if we need we go for a supralaryngeal block. If you are doing a balloon or in an adult patient, we find that it's a safe to go ahead. And spraying using different techniques of using a tri-way cannula with the oxygen. We use a local anesthetic spray, 4% xylocaine, depending on the weight of the patient and the age of the patient. And normally we start with the IV total intravenous anesthesia. So this is a pre-operative nebulization. This is a technique we use. And in our study of 16 cases, jaw thrust has been given in 2 pediatric and 1 adult patient. Tongue sutures, we initially used it, but now we stopped using it. Initially for during the post-extubation so that tongue doesn't fall back. And intubation is required in 2 patients due to blood trickled into the airway. So this was our study, and most of the cases, if you observe, they are mostly on spontaneous respiration. And the maximum duration which we have used it is a bronchoscopy with removal of foreign body. This was the old impacted foreign body, 3 years of duration. And we have to use a flexible scope because it was impacted in the secondary bronchus. And apnea time, which the mean time which we achieved is 34 minutes using a high flow. So a few of the videos that which initially I think this was the first or second case. This was laryngomalacia, and these are the difficult airway situation with the base of tongue cyst where we can't see the airway. So we just first aspirated it, then we marsupialized with the coagulator. So the initial problem with this is using a laser, as I've discussed, it can cause a potential risk of fire, not in the airway, but surrounding part you can have or in the airway, if you are using a dry patties or any other inflammable material in the airway, then there are chances of fire is there. So now we try not to use it in the airway because here the target is moving, the patient is spontaneously breathing, and there are chances that the fire may go out of the operating field. So these are cases which are very safe once you are using a high flow. This is a patient who is spontaneously breathing, subglottic stenosis, We use a laser initially, and then we did the balloon with the in a spontaneously breathing patient. Like foreign bodies, last in my meeting I showed you that it is very easy to take out a foreign body using a high flow. Now we have combined relaxant with the foreign body. So we are giving, and the other major advantage of using a high flow is once you are doing a posterior dissection, posterior larynx like this contact granuloma. So here I am not using any tube here. I am using that fenestrated laryngoscope and using a high flow, and the whole surgery has been done. The patient was on relaxant and everything has been done with the, because even if you use a HFJV, the cannula will be there, so it will be obstructing the airway. So posterior dissection, like in papilloma also, you can take out the tube, connect the high flow, and then take out the tube and do the posterior dissection, which is very easy because you get an open airway field. And if you observe this, so this is how the response of the patient, adult patient, that is, patient doesn't feel any irritation, doesn't feel any dryness in the throat, and benign lesion you can easily do with the using a high flow without a tube anesthesia. Using a relaxant. So complication is local trauma, epistaxis, excessive pain, neonates may lead into pneumothorax, gastric distension, blocked cannula due to secretion, or failure of high flow might cause delayed intubation, worse clinical outcome in respiratory failure cases. The risk of potential fire is always there because of PrEP solution. It may get fire, and there are fire triangle is there, so there are cable connection, fiber optics. There are few anecdotal reports even from UK also. The patient was I think there was a case of a dental implant, and there was a fire while using electrocautery. So various lesion supplies surrounding airway fire may be there using a high flow. And what is our observation is, once we are using a high flow nasal cannula, we have observed that the oxygen concentration around the patient is around 60%. So which is quite high to get a surrounding fire. So no fuel means no fire. To conclude my presentation, it gives a better surgical field, less post-operative irritation in throat, coughing and malaise, short duration, microlaryngeal procedure, post-operative care surgeries. This is an ICU. We have extended our application. Hypercarbia and respiratory acidosis chances will be less as the airway is not blocked, and air trapping will be negligible. So we are extending application in airway foreign bodies, most of the cysts, subglottic cysts also we are doing it, we're using a high flow. But there is a potential risk of airway fire with use of laser or cautery. Thank you very much.
Thank you so much, Rakesh. This talk was requested by during the previous session, and thank you very much for doing justice to it. But before we start off on HFNC, I'm sure there's going to be a lot of comments and reactions, etc. So quick comments on Jayashree's lecture. Deepak, Jayashree's talk.
Excellent talk. I can vouch for Jayashree. You need a steady head and a steady hand when you're doing these cases. And Jayashree brings in both the steady head and the hand for all these procedures. My question for Jayashree is, when do you use muscle relaxants and when you should not use muscle relaxants in these cases?
Most of the cases where we need to have dynamic study, I do not use any muscle relaxant, and I use muscle relaxants only when the procedure, a definitive procedure is planned and it is, you have an access to the airway, like a tracheostomized patient, and then it's much simpler. And otherwise, most of them will be a lot of topical anesthesia and spontaneously breathing. Only when there is a tracheal resections or those kinds of things where you have a planned situation where you want to do the surgery, there I would like to have the child or a patient paralyzed. Again, the duration of the spontaneous surgery can always intermittently, but paralysis is not always necessary in children.
The other question is, can you or Rahul or both of you can comment a little bit about the effect of SIVO on the airway, effect of all the other agents you're using, like dexamethasone, if you're using that, propofol, what are the pros and cons when you're using in airway surgery? Like, can you just give us a little brief on all the agents?
As far as sevoflurane is very well tolerated by children and adults as well, and it is less reactive, and it is a very good agent for induction of anesthesia. And as far as propofol and dexmedetomidine, most of them have particularly propofol reduces the laryngeal airway reflexes. So that way, the once it is done, it will also help in giving you an airway which is less reactive to the during surgery, and it maintains a very good status. Particularly when you use infusions, they maintain a very steady state of anesthesia as regards using analgesic property as well. And it being a alpha 2 agonist, it has got slightly bradycardia, and it does not cause too much of hypotension, but it keeps it under control. Particularly, this is useful in adults for conscious sedations and things like that. So that way, it will really help in reducing the requirement of anesthetic doses. So that way, it's a very good adjuvant, and it will really help in during the airway surgeries. Rahul, anything more for you to add on?
So the only thing that I'll add, just for anecdotal observation, is that with sevoflurane, you're able to maintain a depth of anesthesia and spontaneous ventilation much easier in younger children, by that in probably 6 to 8 years of age, than older children. For older children, you often have to supplement with some sort of intravenous anesthetic, again, whether that's propofol or dexamethasone. We're using dexamethasone pretty frequently, again, at the doses that you mentioned, about half to 1 mic per kilo. And we're finding our need of reducing the anesthetic requirement from propofol and sevoflurane reduced significantly. One of the biggest advantages dexamethasone has is that it's been shown to maintain the CO2 response curve by not depressing minute ventilation and maintaining airway tone. And so in these longer procedures where you need to maintain airway tone with a long duration of anesthetic, again, dexamethasone with a bolus initially and an infusion really provides a steady depth of anesthesia by reducing the other requirements as well. And we're actually using dexamethasone in transition for significant airway reconstruction from the ICU and then back from the ICU to the OR in expectation of extubation following the reconstruction and ICU course as well.
Lastly, I think we need to have a nice discussion on all the different centers on use of what Rakesh gave an excellent talk. But I see that there are a lot of different centers are doing different things. So I want to know, are we missing something for places which are not using high flow nasal cannula? So I'll need a comment from various other centers as well to see what they do and what are their thoughts, especially Rahul, Jayashree, Anil Patel, if you can share your thoughts as well.
Shall we get Dr. Anil Patel? Would you like to give your views first and then the others follow as a discussion? Does that make sense? Can you unmask Dr. Anil?
Hi.
Yeah.
Hi. Thanks very much. Well, first, I thought all 4 talks were excellent, truly excellent. Just in terms of nasal high flow Thrive, just as Dr. Rakesh has said, the pediatric use of nasal high flow has been principally around maintenance of spontaneous ventilation and using nasal high flow. So even the study that, that was quoted was looking at an extension of the apnea time, but not using it for prolonged apnea times. So whilst in adults, we have thousands of uses, tens of thousands of uses of nasal high flow in apneic patients, extending the apnea time for considerable periods. In children, most of the experience is coming over a relatively short apnea time. In children, the rate of rise of CO2 does not appear to be different to non-high flow use. So in adults, so my own experience is almost 1,200 patients of undergoing airway procedures, and they have an apnea time of just around 30 minutes, and the CO2 rate of rise is controlled. But in children, we're not seeing studies that are showing that. There's a number of reasons why that might be. The biophysics of the physiology of children breathing spontaneously is different to adults. There may be physiological differences as to why that takes place, and we don't really have time to go into those. But in essence, in summary, it seems that nasal high flow Thrive for children is a useful tool, but it may not extend the apneic period for very considerable periods of time. And at the moment, the literature is suggesting that the rate of CO2 rise is really no different to not using it. But it does seem to extend the apnea time in many people, in many children. So that's really where we are. This is still, this is for most of us, this is something that's been introduced into our practice 5-6 years ago. So we're still feeling our way through this. And there's a number of trials going on around the world to try and find out its exact place. In adults, there seems to be a particular use of it. In children, we think there's a particular use for it. There appears to be a particular use for it, but then we need more data and more studies.
Thank you so much. Quickly, Shyan.
Anil Patel about anesthesia.
Okay. Mrityunjay, yeah, go ahead.
Namaskar, Anil. I'm from Aurangabad. You are the one who made me buy Monsoon 202 for high frequency jet ventilation. No one is mentioning about it. It's definitely a better system. It's an open airway thing. You hardly, the cannula is so nice, small, that you get unobstructed view, and low flow, low FIO, and high frequency. And there's hardly any jerky moments and all. It's very surgeon friendly. Actually, you literally made me buy that, and I'm expecting you to come to Aurangabad and talk more. But I take this opportunity to talk. I mean, no one mentions about it now in anesthesia practice and all. And you're the one whom I was inspired to buy it. Please enlighten us more on that.
Yeah, so I agree with you. I think jet ventilation is a fantastic tool. I've used it many thousands of times on patients, and it works extremely well. And interestingly, if I go back 25 years, I would have thought 25 years ago that jet ventilation would be ubiquitous and everybody would be using it. The reality is that it's very straightforward, like for yourself because you're experienced in it. But for people who are coming to it, who are not using it regularly and who are not experienced in it, it can be quite daunting. Just because of the pressure settings, there's a fear around barotrauma. There's a whole number of reasons why what appears very straightforward for people who understandably use it quite a lot is quite daunting to people who don't use it a lot. And I think that's the main reason why it hasn't been as widespread as one had hoped 25, 30 years ago. In children, even, I mean, there are people who are using high frequency jet ventilation or low frequency jet ventilation in the adult population. It's a mainstay of a lot of people's airway work. But in children, it seems to be used even less. And I think that's probably, again, due to a fear around barotrauma using high pressure sources. So there are, again, a few pockets around the world that use jet ventilation techniques in neonatal and pediatric work, but the vast majority of people that I'm aware of don't use it. So it's like many things, it's a great tool. If you use it a lot and you're very comfortable with it, it works incredibly well. But if you're using it intermittently, it can be scary, and you can have more problems with it.
The barotrauma part, I feel, is more big when you use it in obstructed airway. Otherwise, it's an open airway system, and the flow is volume is less. It's high frequency, low volume. No fear of barotrauma unless the airway is proximally obstructed. I feel that I'm using, I mean, it's very good in congenital conditions where obstruction is like laryngomalacias and all. It's beautiful. I mean, it works.
One of the reasons I think nasal high flow Thrive has been adopted in many places around the world compared to, for example, jet ventilation is that the experience base, it's easier to use nasal Thrive than it is to introduce to a whole series of anaesthetists jet ventilation. What typically happens is that even in big teaching hospitals, if you've got a staff of 100 people, there might be 3, 4, 5 people who are familiar and comfortable with jetting, whereas the high flow is ubiquitous in the ICU. People have been using it for quite a long time, and that transition over to anaesthesia has been more pronounced because I think it's just a simpler setup. And on top of that, if you use nasal high flow and it fails for whatever reason, if you Thrive and you fail, you just go back to what you would have been doing anyway, which is you either put a tube down or you put an laryngeal mask in, or you take over with mask ventilation. So there's a number of reasons why I think some things have been adopted and other things have been adopted just by a few specialists.
Thank you.
Shyan, quick comment from you before I go to Dr. Raja. He's got a presentation. Shyan?
Yeah, we use Thrive in adult and pediatric patients. I agree with Dr. Patel. In adult patients, it seems to make a big difference apart from the morbidly obese patients. In children, we're currently running a randomized control study, and it probably it doesn't give us the dramatic benefits you see in adult patients, but there may be some benefits for tubeless anesthesia with prolonging apnea times and reducing desaturation. But we currently are running a study. It's a multi-center study in multiple pediatric hospitals around Australia. We should have some answers for you in a year or so.
Thank you, Shyan. Yeah, go ahead.
So just to reiterate, I think in the pediatric use, a spontaneously breathing child supplemented with nasal high flow, I think is a very valuable tool. And that's many of the cases that Dr. Rakesh has been describing. I think it does add a safety margin and an improvement in the oxygenation. It's when you paralyze the children that we're not convinced that the advantages are there. But in the spontaneously breathing child, it's there. If you paralyze a child, you will get an extension of the apnea time, but you won't necessarily get half an hour. You might get 10 minutes instead of 5, or 3 minutes instead of 60 seconds. But if you're breathing spontaneously, I think it does supplement oxygen. It is, as Dr. Rakesh has shown, a very valuable tool.
Thank you very much. And we'll go to Dr. Raj Shahzadan. Sorry for keeping you waiting, but then good discussion.
Dr. Raman, one small comment over Dr. Mrityunjaya's thing about jet ventilation, because I've used jet ventilation a lot in earlier time thing. the most important in jet ventilation is the high frequency jet ventilation is I stopped using because of one reason is basically we have to have an unobstructed expiratory port. If there is in a particularly in a stenotic lesions, if the expiration is not if it's not open and there is air trapping can occur, and that can cause a fair amount of disasters. And again, in adults, it is not useful in COPD cases. So, you know, these are the particular cases where we do not use them high frequency jet ventilator. But it was a very useful tool all through my early part of my practice, and subsequently, particularly when we learned, and that is way back 40 years ago. So that is, it was a very good adjuvant, but subsequently now better equipments are available, hence nobody is using it. Thank you.
Thank you, ma'am.
So thank you very much for all of you. And I introduced Dr. Raj, who's a professor of anesthesia at Christian Medical College. And as you know, they have a very active pediatric airway center. We won't waste any more time. Dr. Raj, please go ahead. The stage is yours.
Thank you, Dr. Raman. I thank our pediatric ENT team for encouraging us to do all these challenging cases. And we are one center which use a lot of jet ventilator, but unlike Dr. Matyunjay said, we don't have an actitronic monsoon, which can give high frequency jet ventilation in a much more safer way. But we manage with the handheld ventilator, but as Dr. Anil said, we use it as to supplement our patient who's breathing spontaneously, because as Dr. Jayashree said earlier in her talk, it is a tight walk. So if you give a bit too much of anesthesia, patient can stop breathing, and if you are giving too less, he can have a laryngospasm and have other airway problems. So sometimes this talk is probably like a summary of what has been already discussed. So sometimes you get a patient who has already got a diagnosis, but sometimes you have a patient like this with a undiagnosed stridor. So your surgeon may ask you to take for a dynamic assessment, and we have seen in our previous speaker slides, this a patient breathing spontaneously, we can have a wonderful examination of the entire airway right from the vocal cord down to the entire length, and can pick up things like tracheomalacia, whether it is adding to the upper airway problems. So this particular case, as we seen earlier, has got a laryngomalacia, and my surgeon actually prefers to have the surgery, like almost all the surgeons would like to do this without a endotracheal tube in situ. And sometimes the post-surgery, like a tracheal reconstruction, can give you trouble. So here you can see the previous surgery suture line. And when you do these kind of surgeries with spontaneous breathing, and when you occlude the airway, there is a significant risk of producing negative pressure pulmonary edema. So you can start with a spontaneously breathing patient, but when the surgeon is ready to occlude the airway, it's better to paralyze or give a higher bolus of propofol so that the patient stops breathing and there is no risk of negative pressure pulmonary edema. But again, like this is a repetition. So sometimes you don't want to be so heroic. So here you have got a valvular cyst. So we didn't want to have a contaminated airway. So in this particular case, we could actually put the tube in, and with the tube in, the surgeon performed the initial decompression followed by the repair. So this is again one thing which is very crucial is always plan the entire procedure with your surgeon, and the plan for anesthesia will depend on the clinical features, the severity of clinical features, the NPL findings and imaging. And this is something which is probably there for discussion. Is there a role of CT reconstruction in children? And as Dr. Rahul said, your anesthesia technique will depend on the comorbidities, especially cardiac comorbidities, and presence of URI, which will reduce the margin of error significantly. And one thing which we always think in this particular case, is there a loss of airway? Or can I reach a situation of can't ventilate and can't oxygenate situation, which is the most dreaded thing for all anesthetists? And what is the backup plan? So the primary plan and the backup plan has been discussed by the team. So these are the common gadgets. I don't have the luxury of Dr. Mrityunjay, so we manage with a Manager 3 handheld ventilator. So again, I will not go into the details, but we don't have a Thrive in our place. So we use nasal high flow oxygen up to 15 liters per minute, which will suit most of the children till about 8 kilograms, because we can give about 2 ml or 1.5 to 2 ml per kg per minute of oxygen. When you give topicalization, you would have seen the discussion. People were giving from as less as 2% lignocaine to 10% lignocaine, but we are slightly wary when you are giving 10% lignocaine, because the residual block can persist and the child may be at risk of aspiration. This is an extremely important thing. We need to have adequate depth of anesthesia before handing over to the patient, and we use jet ventilation. I will discuss that in my further slides. So when you have a loss of airway, especially at induction, continue the nasal high flow oxygen, and you should rule out functional airway obstruction. So that is why it's important to initially address the airway with a video laryngoscope or a direct scope. So we need to rule out all sorts of functional airway obstruction, and the options at that point are either a smaller size endotracheal tube or a airway exchange catheter, which we use very commonly. So the front of neck access is used as a last resort, and so I'll just show you some videos. So if the child has an IV line in situ, we prefer to have the anesthesia established by the time I do a laryngoscopy. And I do a laryngoscopy, and we use a video laryngoscope. The advantage of having a video laryngoscope is that everybody in the team can see what we are dealing with. So we spray the vocal cord, and during the vocal cord spray, I have an estimation that, okay, my patient has adequate depth of anesthesia for the surgeon to put in his direct laryngoscope. So, but what we need to understand here is when you do this spray, sometimes that can tilt the balance. Even when the patient was reasonably well anesthetized, we developed a sort of laryngospasm. Okay, so how do you break the laryngospasm? So now you can see that the chest is not moving, and you can see that only the abdomen is moving. Okay, so that is a ominous sign. So if I don't act now, patient will start desaturating. So far people all of us tend to tell the success stories, but then sometimes it's you can learn a lot from the failures also. So we tend to give a bit of PEEP, that is the normal anesthetic response, and like Dr. Jayashree said, the response has resulted in abdomen being distended because airway is totally occluded, so abdomen is distended. So this is not good. So we need to deflate the stomach immediately. So we deflated the stomach and handed it over to the ENT surgeon. So because the ENT surgeon can establish an airway with an anterior view scope, and you can see that some bit of oxygen going in, the child saturation got back. But the important thing here is when we had a look at it with a scope, we realized that the entire glottis was occluded by the tumor. So there is hardly no way that I can put in a tube, and I could not maintain the oxygenation for some time. So what we did was we used an airway exchange catheter. You can see that this yellow thing is a pediatric airway exchange catheter. This is the Manager 3, which we adjusted to the recommended airway pressures. So you can see that the chest is expanding well. So this is one important thing. You need to make sure that you are sitting at the level of the chest. So it's nice to have one more good team member who can keep an eye on the monitor and help you. So we have this established so that I can see the child's chest movement, because as all the previous speakers mentioned and Dr. Anil Patel mentioned, one of the dreaded things is a pneumothorax or a barotrauma. So it's important that if the chest is going up, it has to come down. So this is what we did. We actually put in an airway exchange catheter through that gap, and we actually did a salvage subglottic ventilation. So you would have heard the last statement made by Dr. Jayashree. So one of the worry when you put anything down like this, ideally the hole for egress should be at least 4 times more than the size of this catheter. So when you have a situation like this, you may not be able to achieve that. So how do you allow egress of gas? So you can have a Y connector, and you can have the Y connector occluded, and the oxygen flowing means your chest will expand. And when you leave the Y connector, you can have the adequate egress provided you give sufficient time. So in a tube which is as long as this, you may have to give 1:6 or 1:10 time till the time the surgeon establishes an airway. So this is another child. You can see that's betadine. So we in fact had got the front of neck access plan also ready, because this was a critically narrow airway. And such a small baby, as we learned from the previous speakers, the reserve is very less. And even if you're giving high flow oxygen, not prolong the apnea for a long time, especially if the upper airway is obstructed. So extra axial technique is good. So if at all you are putting, you put an extra axial technique. Advantage is that you don't have a catheter inside your working area. So our surgeons prefer it when it's possible. So another important thing is line of sight. So when we are talking about a team, that means a surgeon and anesthetist has to work together. And this is extremely crucial, because surgeon should understand what the anesthetist needs. So if we are happy, then you get a uninterrupted surgical opportunity. So our Dr. Ajoy and his team, we actually give us a very good line of sight. So if I have a line of sight like this, I can put it, this is a steel catheter or metal catheter, which I can use for either oxygen insufflation, or I can use jetting in a supraglottic jetting. And you can do the surgery in an uninterrupted way. So when there is no line of sight, so you can get a couple of minutes or maybe 3 minutes of no line of sight if you are giving high flow nasal oxygen, and but you need to tell the surgeon to get the line of sight back. Okay, so if you are not able to have the line of sight or the airway is obstructed, then there is no point in giving high flow nasal oxygen. So this is another issue when you have your instrument completely blocking the airway, and if the patient is breathing spontaneously, that is again recipe for disaster. So sometimes this vocal cord abductor is of a great help, because that will give you enough space for the air to ingress and egress. So one of the questions which was asked by Dr. Deepak was, should I paralyze or not? So that is one question which the team is very keen. So obviously, if you paralyze, you get a quieter airway, less anesthetic is needed. This is extremely important when you're dealing with a small child, because if you give too much of anesthesia, either IV or inhalation, to keep the child spontaneously breathing, you will take enough and more time to wake up the child. And sometimes if you have to send the child to the post-anesthesia care unit or a HDU for monitoring purpose. And sometimes it's easier to jet, but as correctly said by Dr. Jayashree, we may lose the airway completely. And it's as we lose the tone, the surgeon may need to keep the airway splintered. So as Dr. Anil said, we tend to keep the patient spontaneous with assisted jetting. So if we think that a patient is becoming deep or he has had a period of apnea, at that time we jet. How we do it, I will discuss in the on the coming slides. So it is very important that we work in tandem. So the surgeon has to give us line of sight, and hemostasis has to happen without interruption of ventilation. And intermittent tracheal toileting is crucial, because we don't want too much of blood and debris going down. And we can recognize early signs of laryngospasm because the vocal cords will start moving. So you can spray the vocal cord again with 1% local anesthetic, which will help in humidification if you are not using a Thrive or a Thrive. And sometimes what we can do is, if there is desaturation, you can partly occlude the upper airway with a cottonoid that will act as a PEEP and improve the oxygenation. So humidification and temperature management are important, otherwise that will add to the posterior morbidity. So let us see how we do it. We don't have the most advanced setup. We don't have Akitronic Monsoon and we don't have Thrive. So we have to manage without this thing. So here we are using total intravenous anesthesia because as Dr. Raman said, if you use sevoflurane, at the end of the day, everyone is groggy. And if you do 2-3 pediatric airway cases, so you are completely knocked out at the end of the case. So here you can see that this tumor is completely occluding, and if the patient is spontaneously breathing, we can manage with high flow nasal oxygenation. And if their depth of anesthesia is adequate, you are not having a very rapidly moving surgical field. And there is a bit of a tracheal tech, and we sit on the side so that we monitor the chest movement completely. Okay, and as Dr. Jayashree said, it's important to have a surface temperature probe, because you don't want the child become hypothermic at the end of the procedure. So we don't use carbon dioxide laser much, because I think of the scarring issues. So our surgeons and we are happy with the microdebrider. And we have done surgeries from as small as neonate to the bigger child, and we can do these procedures for as long as 2 to 3 hours. That is because we are combining spontaneous ventilation with a jet ventilation. So when the patient is slowing down, you can use jet ventilation as a assisted spontaneous breathing. So that will just synchronize with the patient's effort, and that will help in eliminating carbon dioxide washout also. So that is one concept which is there, because if you give high flow nasal oxygen, that will not eliminate carbon dioxide. You need some kind of a positive pressure to eliminate carbon dioxide. So these are cases where we have paralyzed and jet. So unlike the previous case, you can see that there is a clear-cut airway at the bottom part. So what we did was, whenever there was a bit of desaturation, we asked the surgeon to stop. We asked him to lift up the tumor from the posterior pharyngeal wall, and we could jet and get the oxygenation better. So that is the beauty of teamwork. So I just wanted to show you a couple more slides. So here what we can see is I have exposed the lower thorax and upper abdomen, so that when I jet, I can see what is happening. Okay, so I see the saturation here, and here this patient is breathing spontaneously, but I am assisting him. So there is a consideration whether to use a target control infusion. When you use a target control infusion, unless you slow down the rate of infusion, the patient can go into an apnea. So what we do is we use a background propofol and dexmedetomidine infusion, like what was discussed by the previous speakers, and we supplement it with boluses. Okay, so this is an important slide. So here I have kept my airway pressure at just one bar, just to make sure that it is set according to the patient's weight. So here, this is connected to a humidified oxygen from the wall oxygen supply, and this is connected to the catheter which is there in the patient's airway. So here you can see that I have the option of turning it this side. So now I am doing a jet ventilation. So you can see I can do jet ventilation looking at the chest movement. And if I want to change my so the disadvantage of jet ventilation is sometimes that can spray and obscure the surgical field. So there is the beauty of Accutronic Monsoon, which is a high frequency jet ventilator, and which will give much more quiescent or quiet surgical field to the surgeon. So here another thing which is important is when you're doing such cases, it's important to have depth of anesthesia monitor. The last thing you want is to have the child being aware. So here we are using entropy to monitor the depth of anesthesia. And there was another concern is carbon dioxide measurement. So if you look at this particular slide, so this is what Dr. Jayashree was saying. So the CO2 was coming empty. So if you have a catheter or a tube in the patient's airway, what we can do is you can, if your patient is breathing spontaneously, you can see the patient is breathing spontaneously. It's quiet, not very tachypnic, and we can actually connect it to a side stream, and you can measure the carbon dioxide. It may have a difference between the because of the high flow oxygen. It may not give the exactly correct picture, but that will give you a reasonably accurate representation of the carbon dioxide. So what we have done is this catheter is connected to a side stream and we do it intermittently. Okay, so we can get a decent bit of carbon dioxide. But generally, if the duration of procedure goes beyond 45 minutes, we make sure that by the time the surgeon would have got adequate clearance of the airway. So carbon dioxide can be measured. So to conclude, ultimately we do all these things to provide a quiet airway without an endotracheal tube to the surgeon. So like all the speakers, I also prefer to give patient spontaneous deep breathing with topicalization, and I paralyze if there is a need, or if the situation demands, or if once we get a decent airway, then I don't hesitate to paralyze, because then I can cut down on my anesthetic. And emergency tracheostomy is rarely needed, but sometimes we, so far we are not had to do it. And open airway is a safe option with an experienced team. And like some of the previous speakers have raised a concern, pneumothorax is a real risk when you're using jet ventilation. And like Dr. Anil said, maybe in a department with 40 or 50 consultants, 4 or 5 may be really comfortable in doing it, because you need undivided attention to the chest movements. And we have to make sure that especially when you're doing a subglottic catheter, you need to make sure that there is a patent upper airway and the catheter doesn't go beyond the main bronchus. So one thing which may be of help in the future thing, especially when you're doing open airway, is a Masimo's oxygen reserve index that will give you an advanced warning before desaturation. And good teamwork is a recipe for safety. Thank you.
Thank you very much. Wonderfully summed up. Certain points require reiteration again and again, obviously. So it's fantastic. Thank you, Dr. Raj, for summing up everything so well. And hopefully, and I need to thank this large audience of anesthetists who've joined us. Thank you very much. If you're not in the team, we won't be able to do what we try to do. So the other question that we need is, I want to ask all the speakers is, do we have your permission to put it up on the YouTube? We always put this up on YouTube. If anybody has got any objection, please let us know, because these are viewed much later also because of preoccupation. Some people cannot attend the live sessions. And can I ask some comments? Dr. Anil Patel, can you give your comments? Anything you want to give? Summing up. Firstly, thank you so much for joining, and I'm extremely sorry I spelled your name wrong.
No problem, no problem. So first of all, I think, as I said, I think all the speakers were fantastic. I thought the last talk was excellent. I think Dr. Jayashree made some very pertinent points in her talk. In terms of pediatric practice, the key is whether it's an elective or an emergency procedure. In an elective procedure, as she said, everything is calm and controlled and manageable. In an emergency procedure, you don't have the time often to get all the right information, to have the right people, to have the right equipment. And I think under those circumstances, and this is probably the most common thing that happens around the world, is that children who are running into problems with airways are not always going to the people on this call in specialist centres. They're often presenting to district hospitals where people may not have the most experience with all those things. So that in each centre, I think there needs to be a recognition that there is different skill sets. There needs to be a recognition that a group of people need to take on the mantle of the paediatric airway problems in that institution that are presenting, and they need to gain a finite skill set which will help those children. When these children turn up to the big centres and big paediatric centres, they're going to get great care and they're going to be looked after by experts. A lot of the issues are outside of those centres, and actually most of the issues are outside of those centres because that's where the children are presenting. So we probably need to translate a lot of this into an easily digestible format for excellent anaesthetists who are just not pediatric experienced in the same way that this group is. Myself included, I'm not, you know, I would regard myself as somebody who is, who has some pediatric experience, but I don't have the same pediatric experience that many of the people on this call do. So I would want I'd want in my mind or in my institution a sort of checklist of things that I should do to keep the child safe, to control the situation, and if necessary, to transfer them to the right people.
Thank you very much. Is Dr. Venkatagiri here? He's the president of the Indian Society of Anesthesiologists. We'd like some comments from him. Is he around? Okay, is Dr. Deka here, the former director of the All India Institute of Medical Sciences? Dr. Deka, any comments? All right. Sohit, anything you want to say?
Yeah, I think these were excellent talks. It was a great learning experience as an ENT to hear from my anesthesia colleagues. There were a couple of things which I wanted to emphasize again as ENT specialist. I think, and this practice might vary from institution to institution, is who topicalizes the airway. So in our center, ENT topicalizes the airway. So we use topical lidocaine and not anesthesia. And one of the reasons is I want myself or my resident or the fellow to actually have an assessment of how easy that airway is. So from ENT perspective, we really need to know what's the best way of topicalizing, and the dose is a very, very important part. I've actually seen ENTs using just squirting topical anesthesia. So the dose which we use is 3 milligrams per kg, and that's pretty standardized. The effect takes a little bit of time to take effect. So I think the best time to actually manipulate the airway after you topicalize is close to 1 to 2 minutes, and the peak time is around 4 or 5 minutes. So most of our airway work is done during that period of time, and sometimes you have to re-topicalize the patient because the effect wears off in 15 to 20 minutes. So I think topicalization is one of the most important steps during spontaneous ventilation. The second part is the type of anesthesia. So we have been using TIVA exclusively for all these airway cases. We don't use SIVO much. And TIVA gives you that beautiful plane of anesthesia. There is no spontaneously, there's no issues with coughing, laryngospasm. And one of the things in TIVA which really helps us is dexmedetomidine or Presidex. And as Rahul was pointing out, one of the most important action is keeps the airway patent. So it maintains that airway tone, which is pretty essential. And lastly, coming to Thrive. So we have used Thrive in a couple of cases. We don't use it pretty often in children. And one of the reasons is laser is actually my go-to tool for doing all these supraglottic or glottic procedures. Even though you can use Thrive, you can switch it off when you're lasering, but then it's the whole benefit of using Thrive during lasering, during the spontaneous ventilating procedures. So we have actually reserved it for kids in which we anticipate a difficult airway. For example, if you are called in for intubation of a child who's undergoing a mandibular distraction, or you know it's going to be a difficult airway, so then only we'll keep Thrive around just in case if it is needed. Otherwise, I'll be inquisitive to see what the results of the RCT comes out, which Shyan was mentioning about use in children. So I really enjoyed these talks. Thank you.
Is Dr. Bharati around, President-elect of the IOA, or rather AOI? IOA is Indian Olympic Association. Sorry about that. Okay, Shan's sleep time, I think. Shan, quick comments? You've traveled a long way here, so we want you to say nice things about us, about the program. You can unmute yourself, Shyan. Can somebody unmute Shan, please?
I got it. I'm unmuted. Yeah, excellent talks by everyone. And I can vouch for the fact that amazingly high quality anesthesia is what I've experienced at Manipal Hospital as well. So Dr. Jayashree, great work. Dr. Patel, yeah, you know, great pioneering work with Thrive, and it's really been fantastic for us to use it for our adult airway patients. and we're continuing to use it in non-laser pediatric airways, and hopefully we'll have some information with respect to its risks and benefits with the RCT. But thank you very much, everyone. It was great.
Thank you. Gautham?
The talks were all...
Sleep time for Gautham also. He's in the easternmost part of the country.
Yeah. Sir, what I feel is maybe in previous coming webinars, we could actually talk about how we can sort of standardize things in our country. Like we have centers like yours or Tatavartis, which are high volume centers. We have centers like which are low volume, but yet we are doing something. But then, as Dr. Patel pointed out, in the periphery, when the child comes with a respiratory difficulty, the primary care people should be able to do at least justice to save the child, to give him a patent airway and can be transported safely. So we can work on those points. Actually, we can discuss those issues. Actually, it's been very nice. Sir. It's been a learning experience for me. Thank you.
Thank you. Thank you. Deepak? Unmute Deepak, please.
Yeah, I am unmuted. So yeah, not much to add. Couple of things I would add. Don't discount the use of LMA when you are in a difficult situation. So that discussion with your anesthesiologist and having a LMA in a difficult airway situation, it can buy you time while you're getting more help. So it is important to keep that in mind. The second thing is when the anesthetist can't get an airway, keep in mind you can load an endotracheal tube on your telescope, and you might be able to guide an endotracheal tube into the airway. So that's an option. Tracheostomy, some people ask like, what is the role of tracheostomy where everything is not available? Again, if you're not sure and that's the only way to secure the airway, you might have to do the tracheostomy first. But as much as possible, you need to think about alternate, and part of this series was, part of that was to think about other ways of doing it rather than just rushing into trach. But if that's the only way you can secure the airway, then you should secure that first and then you can do whatever is needed.
Thank you so much, Deepak. I think we need to end because we are almost at the end of our time. So thank you very much to Shyan, a wonderful talk. Then Rahul, Baijal, thank you so much for accepting our invitation and adding value to this evening session. Jayashree, of course, I don't have to thank her. She's part of the team. And Rakesh, you always come out with innovative ideas. More strength to you. And thank you so much for introducing us to Dr. Patel. Thanks very much to Dr. Raj. Wonderful talk. You summed it up so beautifully. And thank you, Deepak. Again, Deepak, I normally don't thank. He's part of our team. Sohit, thank you so much. Karthik from Stanford couldn't join because he had an emergency bronchoscopy. So, you know, it's alive and kicking. Pediatric otolaryngology, airway surgery is alive and kicking all 24 hours. So keeping us occupied. Gautham, a wonderful center you've built up. Congratulations and keep up the good work. And if I've missed out anybody else, I'm sorry, but thank you so much to the audience and to Dr. Prahlad, who's made this possible week after week. And I told him that this is a camel in the tent. We've come to stay in this place and we're going to stay here till we exhaust all the topics. Like a typical never-ending serial, we're going to go. And please be with us and support us in this endeavor. And thank you, Yogesh from Nepal. Thank you, Dr. Siddiqui from Pakistan. Thank you, Dr. Hesavardhane from Sri Lanka. And we're going to have somebody from Bangladesh. So we're going to make it into a subcontinental affair and be with us. Thank you so much. Good night.
Thank you.
Thank you all. Thank you all. Good night. Good morning. Take care of yourself.
Good night.